Good morning. Can I welcome members, invited guests, and the public watching on the webcast today's meeting of the Health Committee. In accordance with government regulations, we're holding this meeting on a virtual basis with Assembly members and guests participating remotely. I will call Assembly members to speak by name during the question and answer session, and I will also introduce each guest shortly. Today we're discussing the experiences of the BAME Londoners during the COVID-19 pandemic and the effect of lockdown on London's mental health. We encourage anyone taking part in the discussion on social media to use the hashtags #AssemblyHealth and #COVID-19. First of all, there are a few items of formal business to go through. Can I ask our clerk, Lauren Harvey, to confirm the names of the Assembly members who are virtually present at the meeting and any apologies received?
Chair, we've received no apologies for absence, and the Assembly members currently present on the call are yourself, the Chair, Assembly Member Sahota, the Deputy Chair, Assembly Member Boff, Assembly Member Desai, Assembly Member Hall, and Assembly Member McCartney.
Thank you, Lauren. Can I ask members to note the list of offices set out in item number 2 of the agenda, and also ask if members have any other interest to declare?
No.
I take that note. Can I ask the committee to confirm the minutes of the meeting held on the 25th of June 2020 to be signed by me as a correct record? Thank you. Can I ask the committee to note the completed and outstanding actions arising from the previous meetings and additional correspondence received?
Noted.
Great, thank you. Well, that brings us to today's main item. This meeting will be in 2 parts, and the first panel of guests will be discussing the experiences of the BAME Londoners during the pandemic. And the guests for panel number 1, for the first panel this morning, are Dr. Soman Banerjee, Director of Public Health, London Borough of Tower Hamlets, and also Professor Gurjit Randhawa, Professor of Diversity in Public Health and Director of the Institute of Health Research at the University of Bedfordshire. Welcome, Dr. Banerjee and Professor Randhawa. Thank you very much for coming. So I will start off with the questions. We have 1 hour, 15 minutes for this session. I'd like to ask you to be very succinct in your replies, because last time the Health Committee ran for 3 hours, more, nearly 4 hours actually, and it's very uncomfortable for everyone. So can we please be very focused in our responses, and if you feel that there's something you want to add afterwards, you can still send information later on. So don't feel that we're trying to cut you, but that we have a time limit on the meetings. So Professor Professor Randhawa, I'll start off with you first. What steps need to be taken to better protect BAME Londoners in the event of a second wave or any localised spikes we might get in infections? What do we need to do more?
So thank you for inviting me. I think the key issue is we need to think about this bigger than BAME communities. Health inequalities are a complex interaction between age, gender, ethnicity, and social class. And what we do know about COVID-19 is clearly your risk of infection is your biggest issue that we need to solve. So I think unless we start to really understand the complex interaction of reducing people's likelihood of getting COVID-19, then we're not going to be able to tackle this. And I think one of our challenges is that in the UK, we've got probably the most progressive laws around equality. So if you think about the Equality Impact Assessment, Public Sector Equality Duty, the Equality Act. So we've got some fantastic instruments, but for whatever reason, to date, the government have not used those tools. So I think the key issue is that locally, London needs to start using those tools like equality impact assessments, the Equality Act, to make sure that whatever they're going to put in place locally in terms of test, trace, isolate, in terms of opening schools, in terms of supporting the employees to go out to work, that they make sure that nobody is unfairly disadvantaged. And if we do that, we will find that not just BAME communities, but all communities in London will benefit.
Great. Thank you. And what can be done to ensure that the historical issues with the BME community having access to healthcare services can be improved to ensure that those who need it seek the care, that they get the care that they need? And I mean, if you look at historically, why has the BME community been affected for whatever reasons, and what can we do to improve those?
Well, that's such a big question. I mean, the simple answer is if we look at previous evidence around the world, pandemics and the impact of pandemics tend to mirror the structural inequalities in any society. So in a sense, what's happened in the UK in terms of the impact of COVID-19 should not be a surprise, because we could have just looked at the history books and we would have realised that poorer communities, those at highest risk of exposure, need maximum protection. So we knew back in January, February, from the data coming out of China and Italy, that if you like, the elderly, those people in frontline facing jobs, those with underlying conditions, had the biggest risk factors in terms of being exposed to COVID-19. So we knew that. For whatever reason, in March, when the Coronavirus Action Plan was published by the government, it really made no reference to any of those three core issues. And I guess that's our learning. And I think for me, it's quite frustrating, if I'm honest. You know, I've worked in health inequalities field for the last 25 years, and I can reel off back from the 90s. We had the NHS Ethnic Health Unit, we had the Tackling Health Inequalities Programme, we then had something called Race for Health, and then back in the sort of recent years, we've had the Prime Minister's Race Disparity Audit. And I think the challenge has been with all of these initiatives, there's been a lot of initiatives, if you get my point, there hasn't been any accountability. So even now with the Public Health England review, you know, they've set up a commission, which is fantastic, but where's the accountability going to be for the actual delivery? And I think that's going to be the key challenge going forward, that whose day job is it going to be to make sure that health inequalities don't widen? And I think until it becomes somebody's day job, i.e. everybody's day job, we're going to keep on facing this conundrum. And I do hope that London can take the lead on this.
Yes. The other thing, Professor Lundawa, is that none of us know exactly what the reason why the BMA community have been affected conclusively, right? I mean, there are a number of theories put forward that COVID-19 has exaggerated the inequalities that the BME community has faced, that they're in the frontline services, they work in a low economy, they have overcrowding, and yet these are some of the theories being forward, and also that they have pre-existing conditions like diabetes or other. But to get to the real answer, right, of why the BME, do you think that we need to do further research, and what should that further research be about?
So I think we shouldn't dismiss those theories as you describe them. I mean, they are the key reasons why the risk of transmission is much higher amongst, for example, BAME communities, because if you're unable to socially distance because you work in a public-facing job where home working is not a possibility, where you are having to go out to work because you're on zero contract hours, you experience high levels of poverty, you live in more overcrowded housing. These are real issues that we shouldn't just openly dismiss. So I think that's the key issue that we need to solve as a country. We need to accept that there are inequalities in this country, and they are particularly impacting upon our BAME communities. And I think if we acknowledge that, we have a chance of solving it. So I think that would be my key point, that we must accept where we are in order to go forward. And I think then in terms of going forward, I mean, I think, you know, there has been some sort of challenges. For example, if you look at the recent survey from the British Medical Association, you're still seeing less availability of PPE to BAME staff in the NHS. You're still seeing from the Royal College of Nursing survey less PPE available to BAME nursing staff. So we're still seeing inequalities in the system. And it's the same now we've seen with test, trace, isolate, and with all the government messaging around social distancing. There hasn't been any culturally competent, tailored messaging. And with all due respect, you know, you're one of the most, if I may say so, most learned people in this field, having worked on, for example, organ donation campaigns, you would know that unless you build trust within communities and you work with trusted messengers and tailor your messaging, you're not going to get the traction you would want from the communities to deliver real behaviour change. And unfortunately, all of this work has been completely invisible until most recently when it comes to COVID-19.
I mean, you drew earlier on the attention to the government inquiry, which hasn't produced any result. But do you think it's a case for London itself setting up a London Commission, right, look into these issues and see what can be done, particularly for London, which may leave the government can be doing their own work, right, but there are specific issues for London. Do you think there's a case for that?
I think there's definitely a case for localised action plans, because I think that's so my day job as a public health professor is to not just train the next generation of public health practitioners, but is also to support not just the UK but across the world on public health issues. And if you look at all the World Health Organization pandemic guidance, it always talks about localized action plans. And again, I think that's something that we've missed a trick on in this country. We started off with this national plan with a national lockdown, and that's not normally how you would manage something like a pandemic. You would have local plans to suit the, if you like, rates of transmission in your local area. You would then actually have local lockdowns from day one. And because if you look at places like South Korea, Taiwan, that's how they managed it from the beginning. There then isn't a stigma when there isn't a when there is a local lockdown. Whereas in this country, we've reached this terrible situation now where, you know, geographies feel stigmatized when they're now going into local lockdown, whereas actually that's good public health pandemic planning. So I would definitely urge London to come up with its own local action plan, but make sure there is clear lines of accountability for delivering it.
Good, thank you. Before I go to Dr. Banerjee, I want to bring in Assembly Member Boff.
Thank you, Professor Randoa. I'm getting from what you're saying is that you're calling on the government to review its policies in the light of COVID-19. Is that fair to say?
Well, I think so. We all learn from these initiatives. So I think the key learning is, and I guess you could say I'm biased about this, is in academia there are two approaches normally to managing issues. There's a medical model, which I believe the UK adopted, or there's a public health model. And very briefly, a public health model assumes you can, as far as possible, prevent people getting COVID-19 or reduce the rates of transmission. And I think that's the way we should have gone. So right from day one, our emphasis should have been on protecting the public, protecting the family, protecting communities, which would have meant that we would have focused on implementing local community test, trace and isolate. Whereas instead, because I feel maybe because of the membership of SAGE or maybe because of the politics of the situation, we adopted a medical model which was all about protecting the NHS. And if you get into protecting the NHS, you're basically assuming that everyone or a lot of people are going to get COVID-19, and therefore you invest all your resources and energies into ventilator capacity, bed capacity, etc. And I think, you know, what I would argue for is far more of a public health approach. So it's the old adage about prevention is better than cure.
Do you think that the mayor as well should review his policies in light of COVID-19 as well?
Well, I think it's always
with that public health emphasis in mind.
Yeah. So, well, I think here is the irony. I think now we've got to sort of August. We're beginning to take a public health approach. We're beginning to see, if you like, the local directors of public health be given a bit of autonomy. And I do empathise with them, because had they been given the resources and the autonomy at the beginning, I think we would have been in a much stronger place, because they know their local communities. They would know how to mobilise the local communities. They would know how to develop tailored messaging. They would be able to put that infrastructure in place. So I would definitely urge the mayor to take a public health focused approach and temper that with, if you like, a parallel medical approach, but not the other way around, because we've got to learn from those countries that have done really well, and they've definitely championed the public health approach.
Do you think that public health approach would also help in the Mayor's housing policies? Because, as we know, there's a direct link between the likelihood of getting COVID-19 and overcrowding. Do you think that would be a sensible thing to do?
Yeah, so public health should really underpin everything we do. I wrote about this back in 2007 for the Race Equality Foundation, that if you take a whole systems approach, as you're alluding to, then not just transport, but education. So if you think about the current debate about opening schools, if I may, I'd like to use London as an example. I hear that it's likely that free transport for school children is not likely to be feasible in the coming months. Well, that's going to have a huge impact in terms of public health, because in London we've got seven of the most out of the 10 most deprived boroughs in the UK, and they also happen to have over 50% BAME communities. So if they're now having to, as families and communities, spend money on transport to get to school, money that they may not have because of, as I said, this interlinkage between your likelihood of a good job and good housing, you can see how we are potentially risking widening health inequalities at this very delicate stage. So definitely agree with you. We need to think about access to affordable transport, and not really free transport for children, and also good housing.
Thanks. So that's a call on the Mayor effectively to revisit his housing policies in the light of COVID-19.
Well, I would say it's a call on the Mayor to revisit all policies in the context of COVID-19.
Thank you very much, Chair.
Well, thank you very much for Professor Randhawa for making the case for free travel for all children under the age of 18. And I hope, hopefully, they'll get. Hopefully, the government and the Mayor will be listening to that. Dr. Banerjee, you're a director of public health, but you also represent public health in London in the widest context. There's this question that the BME community feel that they've been let down by public health. Do you think that how can the public health department win the confidence of the BME community?
Thanks very much. I would go back to what Professor Randhawa was talking about in relation to trust, and there are a number of things I think would signal that we are prioritising and working on behalf of BME communities in our boroughs and across London. I go back to the disparities report and the Beyond the Data report that came out in June. And I think that actually in the Beyond the Data report, I think there's some very simple, straightforward recommendations which build on everything that Professor Randhawa has just talked about. And those provide a kind of foundation for developing that trust. So just really quickly on those sort of recommendations, or the key things that I perceive from my perspective. Right at the front of that is the bit about data. Now, if I look at if I sort of reflect back on the first wave, it was only after about 2 to 3 months into the pandemic that people started talking about the disparities. And what I think one of the key things to bear in mind is that data is there all the time. We are continually collecting ethnicity data, and it's available, but it's not used. So Professor Randhawa was talking about equalities impact assessment and those sorts of tools that we have, which we've been sort of, using it over many, many years, but not really applying as effectively as we should be. So interestingly, through the pandemic, I was getting daily information from the CCG about the state of the health service, regular information. None of it is disaggregated by ethnicity. And so if you are not seeing that data, you are not able to respond to it in a timely or a real-time way. So what would signal that for instance, the health service was taking this seriously would be if that was part of the ongoing monitoring system. And as Professor Randhawa was saying, that it's part of the accountability. So actually, really, people in the system are held accountable for how they are looking at these disparities. So I think that's like one set of things, and I think that's very doable. The NHS have the data, councils have the data. We need to step up on that, and I think that is what is behind that recommendation of the disparities report. The second one is simply around, I think, the community and engagement elements of this, and this is very much what I'm doing in my borough, and I think all directors of public health are kind of leading this work in their boroughs. And actually, the support from the local outbreak fund is welcome, because it really needs investment. So it's understanding the groups that are really at high risk, and recognizing that you need to go out to them. All our engagement work just essentially says that people trust people from their own communities. And what that means is that we need to work with those communities, and we need to educate and train people. Actually, very, very simple messages that can be disseminated through the community. So it's not necessarily us in the council, although we have, really through this process, we've had a role around very direct communication with faith leaders and all sorts of groups across the community. But what we really need to do is build that capacity within the communities, so there are trusted people who can disseminate clear messages. And I think that face-to-face and the demonstration that we're taking this seriously are really central to our response.
Good. Thank you. And the other thing is that early evidence backed by the ONS research indicated that occupational exposure was causing some of the worst outcomes for people of colour. Did policy change to reflect this? And if so, when did it change?
So that information came out, I think, towards the end of April. Mm-hmm. So it indicated that there were significantly higher death rates in occupations, obviously, which have a high proportion of BAME groups. So chefs, cab drivers, carers, etc. So in terms of how we're responding to that, not necessarily in terms of change of policy, it means that we need to really step up how we engage, because those groups are groups that actually we don't, are sort of somewhat under the radar groups. And unless you really reach out to those groups through sort of environmental health officers or community volunteers, you're not going to be able to access those groups. So I wouldn't say there's been a change of policy, mm-hmm. but there is definitely a change of emphasis and a recognition around, actually it's those, I mean, I guess from my perspective as a sort of director of public health, I worry a lot about the groups that I'm not engaging with. I worry about, so we do a lot of work with faith leaders, we do a lot of work with workplaces, but I worry about small mosques, who may be struggling to implement social distancing, for whom the messaging may not be getting across. I worry about small private cab companies. I worry about the requirement for people who are symptomatic to self-isolate and their contacts to self-isolate for 2 weeks. And if you're an Uber driver or a cab driver on a 0-hour contract, how do you manage that? And so that has an impact on contact tracing, who actually admits to being a contact, and all of those issues. They really play out in populations such as Tower Hamlets, where you have this disproportionate number of occupational groups and you have these issues around deprivation, and the economic impact is really significant.
Great. Thank you, Dr. Banerjee. I'm going to bring in Assembly Member Desai, who actually represents Tower Hamlets also. Umesh?
Thank you, Chair. Dr. Banerjee, in terms of what you just said about occupational exposure, does this raise the issue of sort of more robust enforcement by various agencies, councils? For instance, I'm trying to think of other enforcement agencies, but say take Leicester, where reportedly 10,000 people were and possibly still are working in very cramped conditions, akin to modern slavery, as some experts have called it. Does this actually pinpoint the need for local authorities and other enforcement agencies to be much more robust in how they enforce legislation around minimum wage, around working conditions, and so on? I mean, you talked about Uber drivers, about small takeaways, and so on. A fantastic example was just yesterday in Barking Dagenham, another council that I represent, where the council leader with a local enforcement officer went to a Sisha lounge which had been closed down for breaching COVID regulations. And the message was very robust, that we put people's lives before your profits. And if you don't play by the rules, you'll be shut down. So what I'm asking you is your views on enforcement.
So I think that's absolutely correct. I think there's, just going back to what Professor Randhawa says, our approach is both prevention and minimisation of transmission. So we have the legislation locally, which is that if we think there is a situation in which there is likely to be, or there is a high risk of an outbreak, local authorities have the power potentially to close down events or premises. And so there is I think there is, as you say quite rightly, I think there's a very basic issue that if that is our assessment, then that is an option open to us. At the same time, as well as enforcement, I think we need to do that basic engagement, and we need to be working with, in these settings to ensure that they've got the right information, and also to support them to implement the measures around social distancing and hygiene. So it may be that, this happened through the pandemic, is that we went out to premises in which we saw that there were some issues, and we didn't need to do enforcement because we spoke to their management and we said, okay, we can help you with some of the queuing, we can help you with some of these issues. So there is that side of it too. But if there are issues in which we think that we cannot be assured that there isn't a risk of transmission, we have that option open to us. And we are, in Tower Hamlets as in elsewhere, we are seeing a rise in cases now. It's a gradual rise. We are seeing that the R number, the reproduction rate, is close to 1. So we're in a risky situation. And when we see things happening, and we're looking at what's happening in Leicester, we look what's happening in Blackburn, and we know that things can change very quickly. So you're right. We need both of those elements, both enforcement and support and engagement.
Thank you. Let me just come back to the point on enforcement again. I'll tell you why, Dr. Banerjee, and you might also wish to come in, Professor Randhawa. From what I can see certainly around East London, but and this is borne out by some of the evidence that has been presented to this committee and the disproportionality in COVID cases and deaths amongst London boroughs that have the same characteristics. So different areas of London have similar demographics, like I've said, like high number of BME residents, yet the impact of COVID has varied widely. Now, I mean, what is your own personal view about this? What explains this variation? I would argue that the enforcement or lack of it in some boroughs is actually a major contributory factor.
I would imagine that if you look at the variations across London, there'll be a number of explanations for that. You know, obviously because different BME groups have different characteristics. There's, you know, the issues around housing and overcrowding and deprivation will play out differently amongst different BME groups. So I would imagine that is part of it. I do think that the capacity for enforcement across London varies a lot. So, you know, different boroughs have different levels of environmental health officers, trading standards officers. So I think one of the issues that may become manifest if there is a second wave is the varying ability of councils to respond to local outbreaks. So, you know, if there is a need for, you know, quite an intensive local response alongside Public Health England, and there is a need to go out into the community, into settings to implement enforcement, I think what you're likely to find is that capacity is going to be different in different boroughs. So the ability to respond may vary.
Yeah, are you done, Umesh?
Thanks, Chair.
Okay, thank you. Can I bring in Assembly Member Hall, please?
Thank you, Chairman. If I can just, Dr. Banerjee, can I just go through just something that you said before? I mean, is there now an acceptance then that it's because for whatever reasons, and I do understand reasons in many instances, that the virus is more prolific in BAME people because so many are unable to keep to the rules? Is that what you were saying? As in the cab drivers, etc. They can't afford not to work, so regardless they're going out. Is that what you're saying?
I think what I'm saying is that, you know, if you look at the situations in which people lead their lives, there's going to be variation in how easy it is to self-isolate if you're if you're a contact, if you're a case, or if you're a contact, because of the you know, issues around actually just your living environment.
Yeah.
So I think that it's actually, you know, my experience is that people do their best in the circumstances that they live in their life circumstances, but it's harder for some people than other people. And I think that if you look at the, you know, just essentially, if you take the BAME groups and the kind of wider determined, the sort of social conditions, it is inherently harder to exercise some of the sort of key hygiene and social distancing measures that are needed to contain the virus.
Okay, so that's more likely to be it, as in they are out there more for whatever reasons than any, I don't know if this is the right term, physiological reason. You know, there's nothing of a BAME person's body makeup that would make them more susceptible to the virus. That's what I'm trying to say.
So,
what do you think?
Yeah, so I think that is very inconclusive. You know, if you look at the explanation for the disparities are that the are the reasons that Professor Randhawa and myself have talked about. Although at the same time, there are there are certain conditions that may make being infected more severe. So if you look at diabetes in the South Asian community, a higher proportion will have diabetes. If you have diabetes and you have coronavirus infection, there is a likelihood that you'll be affected more significantly. But it's not, there's nothing sort of genetically that's been demonstrated, as far as I'm aware, that kind of makes BME groups more susceptible.
Right, that's really interesting, because at one point that was being talked about. Was there something, because BAME communities have been affected so badly, and so many doctors who obviously do know the rules and one would hope would keep to those rules, and it has been mooted at times that BAME staff need to be protected more than other staff in businesses because they are more likely to be getting this virus. I'm sure everybody's interested. Is it something in their physiology that is different? And you're saying you don't think it is, which is interesting.
Yes.
I mean, and Sobly, if there was, then we need to find that out so we can protect those groups. If it isn't, and it is down to whatever reason that they have, that they're not keeping to the rules, that's a different thing completely and needs to be dealt with. It's an interesting point, and it's something I think needs to be ironed out so that we know which ways are best to deal with it. Okay, thank you. I'll move on to the next question, because it's an interesting subject that really we've got to get to the bottom of, haven't we? So to both Professor and Doctor, how do communications around public health for BAME communities need to be improved? Whichever one.
Start?
Yes, lovely. Professor, please.
So again, there's a plethora of evidence that shows that if you want improved health outcomes, then you need to have what we call culturally competent messaging. So that's not just about ethnicity, it can be about education, gender, etc. So, I mean, you can learn a lot from advertising. You know, a lot of companies invest billions of pounds in trying to work out how to sell us products. And it's the same kind of thinking that you have to think about in terms of behavior change, in terms of healthcare. So I've done a lot of work, for example, on diabetes and around diet and lifestyle. And what we know is that if you truly want people to change their diet and lifestyle, they're far more likely to engage with that if they have peers that they can connect with and identify with who are giving them that messaging. So, for example, if it's someone, I'll take my mother as an example. You know, she came to England in the 60s from India. So she's more likely to identify with someone of a similar generation who can either speak in English or Punjabi. We're Sikh, so maybe is affiliated to the local Gurdwara, place of worship, who's experienced diabetes and can talk to them about how they adapted their diet. So, and I think here's the irony. We've known this, so this isn't new knowledge. We know that culturally competent, tailored messaging improves health outcomes, and we know that globally across the world. It's not a phenomenon true to the UK. And this is why, you know, I am literally flabbergasted that the original coronavirus action plan produced in March made no mentioning of tailored messaging for the UK's diverse population when they first started talking about social distancing, lockdown, etc. So, you know, it is quite serious that we've managed to omit something so simple and so obvious. And again, you know, I would like to commend the very many communities who've stepped up. So personally, you know, pre-March, pre-lockdown, I worked with the Sikh channel, who are a big media outlet in the Sikh community, and they started to convene fortnightly TV programs, reaching out to their audience, their congregation, to start communicating about the importance of social distancing, washing hands, etc. And I know a number of communities have done that at local level and national level. But as I said, these are bigger missions, you know, and we really do need to reflect on why we managed to sort of put aside all of this fantastic evidence base that we've got around concordance and improving health outcomes, and then didn't apply it for COVID-19?
Well, perhaps they were just concentrating on COVID-19, and it's the underlying health issues that perhaps should have been looked at through communities a lot earlier. But if they're putting stuff out for COVID-19, it's been such a big thing. I think the biggest thing to find out is if it's the underlying health issues that's causing this, no matter what background, etc., and of course your lifestyle or your ability to not go to work, etc. I think once we've established that, that's far more important, really, because you can move on from that as to wondering whether it's something within different groups that would cause them to be more likely to get it. Did you have anything to add to that, Dr. Banerjee?
Yeah, thanks. I mean, it just builds on what Professor Randhawa said, which is, I think, listening to communities is absolutely fundamental. Which is, so over the past few months, we've had a lot of sessions with a whole range of diverse groups across Tower Hamlets, and you hear things which kind of indicate that the messages have not been taken forward or not being understood, but also that people don't feel listened to. So therefore, that whole process of sitting down and listening and shaping your response in response to what you're hearing develops trust. And as Professor Randhawa was saying, is actually one of the key bits of our strategy is to ensure that we are equipping people within communities to speak to their own communities, because that's the best way to get the message across. So that's I think, and across London, I think a lot of directors of public health are doing similar things, which are developing, building up, actually building very much on the volunteer effort, the amazing volunteer efforts that happened through COVID, the pools of volunteers that have been developed. Obviously, that's, as people go back to work, that pool is slightly diminishing, but that is a very valuable pool for us to get messages across into communities.
Well, clearly that's got to be done, and judging by what both you gentlemen are saying, that's got to be done by the communities, if that's who people trust, somebody within their own community. I mean, has such a large focus on the BAME communities during this crisis had any negative impact on those communities? I mean, has it caused any discrimination of any sort? There's been odd reports about this. What is your view, either of you?
I can kick off on that one. I can't speak for my borough, but I do listen to the Directors of Public Health where there are currently lockdowns in Blackburn and Leicester, and that has caused, I'm aware, community tensions because of the way things might potentially be framed. So that is definitely something that we need to be aware of in responding both nationally and locally in our response.
Okay, got anything to add to that, Professor? No.
Yeah, I guess sort of 6 months is a long time, but I think if you think back to January, February, we were at the time of government trying to seal the deal on Brexit. There was still the ramifications of the Windrush scandal. So if you like, the whole narrative at that time was very anti-immigrant, anti-BAME, etc., which kind of then, in the last 6 months, we've seen, the rise of the Black Lives Matters movement, and a far greater push now on the debate around inequality. But I do think we all have a responsibility, because I still think the way some of these debates are framed are really unhelpful, because when we talk about BAME communities, we keep on trying to blame them. So, are they to blame? Whereas no one gets up in the morning wanting to either harm themselves via COVID or harm anybody else. Everybody is literally trying to put food on the table and pay the bills and live a healthy life as they can. And I think we do need to understand, and I think this is the hard truth. In the UK, there are structural inequalities that disproportionately affect black and minority ethnic communities. Once we accept that, and that applies to housing, transport, health, education, then we've got a fair chance of overcoming it. And once we start to do that, we then can start to see, hopefully, a better debate. So take the Leicester and Blackburn debates. The way that's been portrayed in the media, it's all been about BAME communities, but yet nobody talks about the beaches and parks as being a white problem. Yeah, colour never comes into it. And I think that's where we all collectively have a responsibility to debate these issues in a far more nuanced way.
Okay. Right, I'll move on to the next question. This is to you, Professor. How would you assess the awareness and preparedness of public authorities at all levels for reducing the health inequalities impact of the pandemic?
So let me start off. I mean, what I don't want, and this is what my candid fear has been, is I wouldn't want the principal outcomes of COVID-19 to be an increase in health inequalities. That's my biggest fear. And I say that because, understandably, lots of primary care GP surgeries have moved to online or phone modes of delivery. And I don't know how many of you will remember this, but we used to have something called NHS Direct a few years ago. And I was commissioned to do the national evaluation of that. And what we showed was that older people, lower socioeconomic communities and BAME communities were less likely to be able to access and navigate phone-based and online services. And this is now my real fear with what we've seen during COVID-19, that whilst primary care has remained open, and I know GPs have done their best, I think there are some unintentional consequences to this, that unless you support communities to still have, where it's possible, some kind of option of safe face-to-face or some peer support to how to navigate online or phone technology, because it's not just about turning on the technology, it's about having the ability to articulate one's symptoms using either a phone or using online technology, and that comes with time. And I'm sure I can't be the only one. You know, I've had to adjust, although at university we've used all these Zoom, etc., and Microsoft Teams for years, it's still taken a period of adjustment for me to do this pretty much every day, all day for the last 6 months. So imagine that for someone who doesn't have the resource or the education that I've had. So I would urge local authorities across the country to really think about how they can work with health and social care providers, also with schools, to make sure that everybody is not left behind when we talk about digital inclusion. So I'm very worried about lower socioeconomic communities, older people, BAME communities. You know, there's lots of people who are potentially going to miss out while we talk about a digital future.
Okay, let me tell you, Professor, there are very many of us that are missing out by only being able to, and that's the ones of us that can access the digital world. It's hit and miss where you live as to whether you're seen or you're not seen. And that's not just a BAME issue by a long, long way. And I sincerely hope GPs are able to go back into dealing with people in a proper way. So I wouldn't get me started on that one. As an academic in this field, would you know who to make representations to, people that, you know, will make the decisions going forward to assist with what you've been saying, really? So
I think, you know, the learning from COVID-19 so far has been, I think we need to make those representations at every level. So definitely at national level, NHS England, the Prime Minister, Matt Hancock, they all need to be hearing the fact that, you know, we need access to healthcare for all communities of every ethnic and social group. And that needs to be real and meaningful, which is why we did see a few weeks ago a plea from government that people should still attend hospital for their routine appointments, because there is recognition that people are missing out. But also at local level, we need to be approaching our local commissioning groups, local authorities. But I would say, this has to be done at every level. And the most important thing is this does require resource. So I think this fallacy that we can do this within the same resource envelope, it's impossible. It's impossible for any health and social care provider or school education provider to offer a multiple range of outlets for the same amount of money they've currently got. You just couldn't do that. And I think that's where I would like to see the government take a far more coordinated approach, in the same way they're trying to, build up the economy with things like their Just Eat schemes. I think we now need to think about, well, how are we going to ensure that we really do improve access to health and social care services? So what then are the resource requirements for service providers to make sure they can offer this multiple range of access opportunities?
Okay, so if I throw it back at you, how do we as the public make sure that more of our GPs are actually in surgery seeing people so that they can access specialist help?
So I would contact your local CCG. I would definitely contact NHS England.
I mean, for everybody. No, for everybody. I mean, there is a lot of resource that goes into GPs, for example. So how is the profession going to make sure it starts going back doing what it needs to do without just saying, well, we need more money all the time?
Well, I don't think it's about just more money. I think it's about, you've got to develop a new service model. So in order for a GP practice to offer a range of options, that be that safe face-to-face, online and phone consultation, they obviously then need to reconfigure their workforce and ensure they've got the IT infrastructure to do that. And then obviously, if that means more money, you make a case for that. But all of these things need to be done quite quickly, because again, to me, as I said, pandemics, I guess the learning has been that the UK, we've been fortunate in the fact that we've not had a severe pandemic like this in our modern era. But that doesn't mean that we shouldn't have learned from the countries that had. And we knew from those countries, especially in East Asia, that these things, if you look at SARS and MERS, these things happen. And we know how those countries responded. And therefore, they did mobilize a different way of delivering, not just their health and social care, but also education, also businesses, and keeping the economy going. And we need to learn from those countries, and the government should be ready to respond, so that the GPs and the government can work together to make sure that us as patients and the public are well looked after.
Yeah, and the health authorities obviously need to step up to it as well. Not everybody always says the government, but to a certain degree, the experts need to be there stepping up to it as well. I agree with that. Okay, I'll leave it at that, Chairman. Thank you.
As the only GP on the panel, I won't join the debate on general practice on this occasion. But I'll invite an Assembly member, Umesh Desai, to ask his supplementary and also to go take on with his two questions.
Well, thank you, Chair. Can I ask you this, Professor Randhawa? I should have asked you this earlier, but in the context of the questions raised by Assemblymember Hall, I think it's only right that I ask you at this stage, or is relevant at this stage. There's a question that I put to Dr. Banerjee earlier, and obviously Dr. Banerjee is more, works at the ground level in Tower Hamlets. But from your perspective, from an academic perspective, but also the overview that you have of public health work around London and indeed around the country, this does concern me, and I'm sorry, but I'm going to keep on making this point time and time again in various forums, both in East London, but also London-wide and nationally. The different areas of London have similar demographics, the same sort of problems of deprivation, overcrowding, lack of resources, and yet the impact of COVID-19 has varied widely. So, for instance, in East London, that I represent, Newham has had more deaths and cases reported, than Tower Hamlets and Barking Dagenham combined. What is your explanation for this?
So, I mean, I could only answer that. So specifically, I could only answer it if we actually analysed the records of those people who sadly died, and then retrospectively went through their exposure, because I think it is a complex relationship between how people are being exposed to the disease, and then also how they're protected, and then when do they access healthcare. I think the key issue, though, is about how do we support communities, and I mean that for everybody. So again, if you were to look at the World Health Organization guidance on pandemic management, it's not just about test, trace, isolate. It's also about test, trace, isolate, and support. So if you're asking someone to isolate, you should then put in place some support measures to ensure that they're not financially or emotionally penalized for that. And I think, again, that's where the countries who've experienced these pandemics previously, they've known this, and therefore they've put that infrastructure in place. And in a sense, that's where the UK would be a bit slower to respond. So if you've got, for example, a borough where you may have a high proportion of zero contract hour workers, you've then got to make sure, with the support of government, that you can support those communities to not be financially disadvantaged. If you don't have that in place, they find this whole advice about isolation, quite frankly, a luxury. It's not a reality for them. And I think, we've really got to sort of start planning for this in the future and really learning, we can contact those countries now and start to put this infrastructure in place. And I think for me, that's been a lesson right from day one of the COVID-19 sort of management issue, that we've not really, if you like, shown the humility that I would have expected. We could have learned from those countries very early on and brought in those experts, and they would have probably taken to us to where we are now in August, had local infrastructure in place so that local directors of public health, like Dr. Banerjee, could coordinate their test, trace, isolate, support infrastructure. They could coordinate their tailored messaging. We would have been doing that in February and ready for the March outbreak. Instead, we are where we are.
I'm really glad you made that point, because I think places like Kerala in India started in January, and they were astonished that, given that the relative lack of infrastructure compared to us in the West, and I could go on and on about New Zealand and other places. But can I just ask you this point about, Dr. Banerjee talked about training standard officers, enforcement officers, and emphasis given, to enforcement by various councils. Do you think it would help for the Mayor of London to try to encourage more consistency in terms of messaging and enforcement across London? Is there a role there for the Mayor to advocate good practices? I know Tower Hamlets, there's some very good work on enforcement. I've already mentioned Bark in Dagenham. What worries me is the lack of, consistent enforcement, robust enforcement across London. At the end of the day, boundaries are just municipal boundaries, and people travel across boundaries. And unless we have that consistency London-wide and indeed nationally, in a variety of fields, enforcement minimum wage, private sector licensing, cleanliness, fly tipping.
So I think enforcement is just one of a range of measures. Mm-hmm. So again, thinking about pandemic management implementation, firstly, it's about information giving and culturally competent, tailored information giving. It's then about putting in place support measures. And then it's only at the end of that, if you've given tailored messaging, you've offered tailored support, if there are still people who then aren't adhering, you put in enforcement. But it needs all three, and you can't sort of do one in isolation to the other.
I agree, and that reflects, I think, the political orientation of local authorities, something that I won't invite you to comment upon. But just moving on, if I may, to you, Dr. Banerjee, we already talked about cultural competence issues, but before I come to Tower Hamlets very specifically, and I know you already mentioned your borough in the context of cultural competences, talking about messaging, and Professor Randhawa mentioned the Sikh channel. Now, I think that's actually a very, very good point you made. I'm astonished that we don't actually look at the variety of communication channels that we have within BME communities and they needed to get the message out to wider communities. So this sort of stop national message, stay alert, that can mean many things to many people, and I know the government has been criticized for the use of that particular message. Would you accept, how can we encourage councils? I know Tower Hamlets actually has got a proactive communications policy with the Bangladeshi sort of television channels, but how can we actually encourage this good practice to be shared? What concerns me is the muddled messaging. I was speaking to I'm a member of the GMB trade union, and I was speaking to my regional secretary yesterday about job losses in the aviation industry, which could affect huge communities all over London and the south here. And one of his concerns was the muddled messaging coming out, still coming out from the government. And this is where I think the use of more grassroots-based agencies to get across, he meant muddled messaging in different contexts, but in terms of health issues, what have you got to tell us?
So I think one thing that's been quite positive around the test and trace is that the comms has been quite aligned across London. So there's been a sort of safe London, safe Tower Hamlets, safe borough message, and the comms teams across London have kind of become quite aligned in ensuring that the messages are clear and the different boroughs are making the same message. So that's kind of fine, but at the same time you need to localise those messages consistently. And so that's where there are all sorts of different approaches that are possible. You know, we use in Tower Hamlets, we use Channel S to transmit the messages in Bangladesh, in Sylheti, and but also, you know, we work with the Somali community and other communities. And actually, the experience that I've had is that the sorts of mechanisms that really work are very simple. Actually, probably one of the best videos that I've seen over the course, at least in Tower Hamlets, was one in which a GP just asked his patients to set out the key messages. And so what we want to do is, and this is what we've been doing, is getting people within communities, giving them the right sort of messages and getting them to transmit. So that's worked with, for instance, children, but it works with different communities, and that's the sort of direction that we're going in. So I think there's something about the sort of national, the London level and the local level, the alignment of the simple messages, but actually because things change so quickly, particularly if you look at what happened with shielding and how quickly the message changed, and we weren't all given the message in advance. We have to be very, very agile in terms of how we communicate some really important messages. So I think, as you said, I think it's alignment across London, but you know, we're on this every single day. You know, every single day we're going, actually, what's the new message? And you know, what can people do? What people can't do? What is a social bubble? You know, how many people can meet outside? If you're going to a restaurant, you know, all of those issues need ongoing communication in a range of languages to a range of to a range of communities, with people within the communities disseminating those messages. It's a really, you know, it's an everyday thing, but the alignment is really critical.
Thank you, Chair. Yeah.
Thank you, Mish.
Thank you for your answers, both of you.
Okay. Assembly Member Andrew Boff. Andrew, we have 2 questions left in 10 minutes.
I think the panel's been very good and answered a lot of what I was going to say anyway. I just wanted to know from both our guests how helpful the Public Health England second review will be, or is, and what confidence do you have in the report's recommendations being taken forward by the government?
I'm happy to start on that.
Please.
As I said before, I think the recommendations are very sensible very straightforward. They are things that have been as a sort of self-evident, but the power of it is that it comes from a very extensive consultation across the country. So I'm quite sort of simplistic around this, which is that, if you look at this across London, it's a very valid question for every key public sector organisation. What are you doing in response to these recommendations? And to have some kind of accountability around that. I think it would be perfectly reasonable for us as a council to be asked. There was this very powerful report in June. What are you doing around these recommendations? So
can I just ask whether or not you know who it is that's responsible for driving these recommendations forward in London? You can probably name who it is in your own borough, but
so I think, well, first of all, if you think at what is at London level, you've got NHS London and you've got PHE London, and so obviously this report has come from Public Health England, so they need to be exemplars in taking that forward in their organisations. I think there's some really key messages at NHS London level for which they may need to have, or at least feel themselves to be accountable to across the system. So from NHS London perspective, they need to be speaking to the trusts, the mental health trusts, the acute trusts, general practice, and asking them what they are doing in response to the recommendations. I think there's a very real pressing issue, which is, and I think that would focus minds, which is that if there is a second wave, how would you respond to disparities around BAME groups, and use the framework of the recommendations as a way of shaping that question? So, in the second wave, we need live data, we need to be engaging with our communities, we need culturally competent messages going out. So I think there's a real question, and I think the disparities report is a real asset for us. How the accountability works out, I think, is the key question.
yes, because the accountability, as you so rightly said, is very important, and unless we know who we hold to account for driving those recommendations forward, it's a bit of a problem. Professor Randhawa, do you know who is responsible?
So it's on public record that, what I've said previously on this report. So on the one hand, I welcome the report because it's a great resource where everything is marshaled together in terms of the evidence and the recommendations. But on the other hand, being open and transparent about it, there are 7 recommendations, 2 of which are COVID-19 specific. The other 5 recommendations, which relate to health inequalities and ethnicity and social class and age and gender, those 5 recommendations are not new. There are a number of health government reports that have published those same recommendations time and time again, and we've seen very little change. We've also now seen the announcement of a race and health observatory, which again, it's welcome on one hand, but unless they're going to be given the resource, and then they're going to be able to hold the system accountable for delivering their recommendations, all of this is just going to be simply window dressing. So for me, the clear omission from that report, and this is kind of, I think, part of your question, is, the report is completely silent on accountability at government or local level. It's silent on it. So the fact that we all having to scrabble around on it is a serious problem.
Should the mayor step in?
Well, I think...
What's the mayor's role in this?
So again, I would agree. I think at local level, we need to step up across the country and start to show some local leadership to say we're going to hold ourselves accountable for delivering these recommendations. Because I think if we wait for government...
I'm sure you'll agree with me, Professor Randhawa, that holding yourself accountable is never a good idea. You really have to hold somebody else accountable.
Well, I'm sure the Assembly will do a good job of holding the Mayor accountable.
We do already. Thank you very much. You've alluded to the community participatory research on COVID-19 outcomes on BAME communities. Has that really been taken seriously? And how can the Mayor make sure that this research is pushed forward in the future? Because only the other day, only last week, I had a meeting with the Board of British Deputies who were concerned about the messaging going forward to the Orthodox Jewish community, some of whom are not as technologically connected as the rest of us. And so there are some concerns there. So what do you think the Mayor's role should be in making sure this is done effectively?
So I think what those submissions of evidence showed is there are tremendous community assets in London and across the UK. And I think the onus now is on how do we harness working with those communities to ensure that everybody is aware of COVID risks, COVID protection measures, access to health and social care, etc. And also at the same time, there does need to be some sort of maybe London-wide strategy. So one of the things that I always say about conditions like COVID-19, because the COVID-19 is sort of invisible, you can't see it. And although we've got the tragedy of over 60,000 odd deaths now, we've not really seen the seriousness. If you think about how we advertise or get the messaging across about the dangers of smoking, it's quite, explicit about what the damage it does to your lungs. We've got to learn from that. And I think, for example, something simple we could do across London is we could have daily forecasts, COVID forecasts, a bit like, you have your weather forecast for London and different boroughs of London about, it's going to be potentially hot or cold there. You could start to have London borough forecasts of what the COVID R rate is looking like, and therefore people can start to make these far more informed decisions. And once we can get these forecasts out into these communities as well, so you've used, for example, the Board of Deputies as an example, but there are many communities. And if we can all then start using the same information consistently, I think London will be in a much better place.
Thanks. And the Mayor should be driving that.
The Mayor and yourselves.
Good. Thank you. Thank you, Chair.
Professor Brunello, let me whilst have you for a few moments. Earlier on, you were speaking about some of the changes taking place here in primary care, right? But the other thing which is happening is, under the cloak of COVID-19, there's been a reconfiguration of hospital services. And this is happening right across London, and my inbox is often full of what the Assembly should be doing about this. And I, in my own back garden, in the Ealing Hospital, for example, they have shifted services around and run it down into basically an outpatient clinic. But I mean, this reconfiguration is taking place right across the country, particularly in London, and particularly in areas which have BAME communities and have huge inequalities, and there's been lack of consultation. What do you think the London Assembly should be doing about these things happening right across London? And what can the Mayor be doing about this?
So I think all reconfigurations across the public sector, that could be health, social care, education, etc., should definitely be co-designed with the public that we serve, because we have a publicly funded system. So by definition, the public should be engaged. And I think that's what I've been very concerned about. Over the last 6 months, during COVID-19, if you like, the public's voice and efforts to hear the public's voice could definitely be better. And I think, we use the language of co-design, co-commissioning, shared decision-making. And my worry is these are becoming now rhetoric rather than reality. So I would hope that the Assembly and the Mayor could show some real leadership on this and give our public a real voice on these issues.
Good, thank you. Dr. Sen, did you want to say anything else? Dr. Banerjee? Do you want to make any concluding remarks?
Yeah, well, it was just to just build on what Professor Randhawa says, which is that because digital has come so much to the fore over the past few months, the real risk, and I encountered this recently when it was a discussion about IAP services, psychological therapies, is the pressure on individuals to feel that the digital option is the default option, and actually it needs to be framed in terms of choice. So people, it is another choice for people, rather than a kind of, people feeling bulldozed into a way of interacting with the health service that they're not comfortable with.
Great. Okay. Thank you. Well, you've given us a very good lead into the next part of our investigation, which is looking at the impact of COVID-19 on mental health in London. So thank you very much for your contributions, Professor Randhawa and Dr. Banerjee. You're welcome to stay on panel, but we're going to go to the guests for panel 2 now. Okay.
Thank you.
Thank you. Okay. Thank you. Can I now please welcome the guest for the second panel? Is Vicky Nash there? Okay. Lynette Charles?
Good morning, everybody. I'm here.
Good. Welcome. Lynette Charles is the Chief Executive Officer of Mind in Haringey. I'm also, I can see, is Nikki Morris here?
Yes, I'm here.
Hi. Nikki, Chief Executive Officer of Age UK Camden. Welcome. And,
Thank you.
And Sarah McFadden.
Good morning. Yeah.
Great. Sarah is the Head of Policy and External Affairs, British Lung Foundation and Asthma UK. Welcome. We're still waiting for Vicky Nash, yes?
I'm here. Hello.
Hi, okay, Vicky. Vicky is the Head of Policy and Campaigns Mind. Thank you very much. Look, welcome to the second panel, or second part of the Health Committee proceeding this morning. This is the first time we're doing a virtual changeover, and it's gone smoothly, I think, so far. Good. I want to ask questions to Vicky first. Vicky, it's about what has been the mental health effects of the lockdown on Londoners?
Yeah, well, and thanks so much for inviting us, and it's great to sit on a panel with Lynette as well, one of our colleagues in a local mind. I suppose the starting point is that COVID and the coronavirus pandemic hasn't just been a physical health emergency, it's been a mental health emergency. And indeed, we haven't even reached the mental health peak yet. So we talk about waves and ripples and peaks, but we haven't seen the true full extent of what the mental health impact will be on Londoners, or indeed the nation as a whole. What we do know from some survey and research work that we did at National Mind, and there's no reason, again, these figures are national, but I'm seeing whether I can get you a local or a London breakdown. But that survey work, which was 16,000 people, really highlighted the significant impact that COVID had on people's mental health, both adults and young people. Over half of adults said that their mental health had got worse during lockdown, and over 2/3 of young people said their mental health got worse. So it's a sizable chunk of the population that's saying they're really struggling with their mental health. People with existing mental health problems are more likely to say their mental health has deteriorated, but we've also seen a new group of individuals that are coming through the system that would have been experiencing mental health problems for the first time. So you've got both those with existing problems and kind of new people struggling often for the first time. We know that more people are likely to experience poor mental health as a result of COVID, and we've been particularly worried about particular communities and groups, for example, those who have suffered bereavement and the knock-on effects that that's going to have, because the grieving process has simply not been the way it would be normally. frontline staff. We've heard obviously in your previous session about the impact on people from Black, Asian and minority ethnic communities, and also young people, particularly with the closure of schools. Again, we don't really understand the full extent of that. So that's, I suppose, the kind of opening remarks about kind of what impact we've seen, and no doubt we can go into more detail through the session. But it's real, it's significant. The worst may be yet to come.
Yes,
and it's reached a whole new population of people.
Yes, thank you, Vicky. I think I agree with you, particularly listening to a lot of the frontline staff, right, particularly in the NHS, who dealt with the COVID-19 infection when there's a peak, that they are now coming to terms, right, of what they dealt with, right, and some of them have had very severe traumatic experiences, and as you say, I think we will get more and more of the healthcare professionals coming forward with their mental health problems, and more is to come yet. But also people who already had pre-existing mental health problems, they were also they were also exaggerated or exacerbated during the COVID-19 infection. Why do you think that might have happened? Why have the people who were very mentally had mental health illness, they were more affected than people who didn't have a mental health problem beforehand?
Yeah, I mean, there's not one simple answer to that. It's a real combination. Some aspects of that are to do with the fact that some people just simply weren't able to access the support they wanted. So our data is showing about a quarter of people weren't able to access the support they needed. That includes NHS services, and there's we have been hearing messages that the NHS pretty much ran as normal during that time. That was not the experience of a lot of individuals. I think really interestingly, there's a number of adults and indeed young people, in fact more young people, saying that they didn't access support even though they knew they were struggling because they didn't think their issue was serious enough. And obviously there's an element of that public health messaging which was really about encouraging everyone to focus on COVID, but that has come at the expense of people reaching out, seeking help for other physical and mental health issues, and we've seen that in reported through cancer, through lots of different kind of other health conditions, and mental health was no different. Nearly 2/3 of those that said their mental health was poor and got worse said that actually it was the difficulty in trying to navigate and access support that made their mental health worse. So there's really important lessons in there, I think, for when we start to think about potential second waves and what we can do to mitigate against.
Well, Vicky,
against that.
Yeah, I'll say that you predicted my next question very, very finely, which was going to be asked you that should there be a second wave, what steps should be put in immediately to prepare for that, to make sure that people's mental health doesn't get affected? What can we do right away in case there is a second wave?
So I think there's three things that are specifically to do with services that you could start to plan and prep for now. One is to pick up on this issue that was mentioned at the end of the last session around, for example, IAPT and IAPT referrals. So we saw dramatic falls in IAPT referrals and CAMS referrals because those pathways are essentially they weren't functioning. People weren't going to GPs and kids weren't in school, so they weren't being picked up through that. So we need to think about what are going to be the alternative ways that people can seek help, whether that's self-referral or whether we make sure that we really robustly build those kind of referrals from primary care into kind of mental health services, and to start thinking about what that looks like at a pan-London level. The second one is around, we've heard a lot about digital services, and digital services have been great. We've moved so much quicker than we ever thought was possible. But there is a but to that. It's not going to work for everyone. And so we need to think about going into a second wave as having a really good blended mental health offer, so that you can have digital for those that need it, and you also have face-to-face or alternatives that aren't just reliant on digital, because some people, that it's not just they haven't got access, it's simply that it doesn't work for them in terms of engaging with their mental health problem and the support they need. So that's the second one, blended services, and to build that in, not just see digital as like the silver bullet to fix things. And the second one is really to make sure that we get our own house in order between mental health trusts and community services, and that if people are in a hospital, we saw a lot of people really essentially kind of thrown out of hospital into the community, but the community services were pretty there was hardly anything left because the staff had been pulled out to go and work in the acute trusts, and the services had pretty much closed down in some areas. So if we're gonna remove people from hospitals because we want to avoid their catching COVID, we have to make sure the community support is there, and we can definitely learn from what happened in that first wave to make sure that those mistakes aren't repeated, so that people are actually in the best place for them to receive the care. So they would be my top three.
Great, thank you. And I just want to ask Lynette Charles, who's the Chief Executive for Mind and Haringey, did you want to add anything at this stage? Lynette? Okay. In that case, I will call on Assembly Member Joe McCartney for the next question.
Thank you, Chair. My question is to Sarah McFadden, and I would like to ask you about the effect on the mental health of those who have a pre-existing condition such as asthma, and what actions you think should immediately be put into place to protect the mental health of these Londoners, particularly in the event of a second wave or localised lockdowns.
Yeah, thank you for asking that, and thank you for having us along today to give evidence. I think that the impact on mental health of people who had existing physical health conditions such as asthma or COPD or a range of other chronic conditions has been quite significant. So we've been running surveys throughout the pandemic of people who are living with a lung condition, and consistently people have rated that they're feeling a lot of anxiety and a lot of stress about the pandemic. So 2/3 of people with a lung condition rated their anxiety at a level of 8 or above out of 10. So that's quite high. We did have a look at the figures to see if there was a London breakdown, and we can do that and give London specific figures, but we didn't find significant differences in what Londoners with lung conditions said versus other parts of the country. 1 in 5 people said that their mental health was their biggest concern in relation to COVID. So that comes after the impact on their physical health, but to put it into context, only 2% of people said that the impact on their job or their personal finances was their biggest concern. So right from the beginning, people were recognising that this was likely to take a real toll on their mental health. And I think particularly people who have been shielding, which in London, we think that up to 75,000 people with a lung condition have been on the shielding list. And people in that group were feeling particularly anxious and also dealing with feelings around loneliness and isolation. And one thing that we found particularly interesting was that as we kind of started to ease lockdown and started to talk about the end of shielding, people's anxiety actually increased rather than getting better. So I think that while people were shielding, they found that a very difficult experience, but they also felt safe. Whereas now that shielding has come to an end or has been paused and lockdown restrictions are easing, people are feeling, we're hearing this both from our surveys and from phone calls and conversations we're having with lung patients, people are feeling more worried about their risk of catching COVID and a general sense that other people have moved on and may not be taking the right steps to protect them when they go out and about, so not social distancing and so on. In terms of what we can do, I think there are sort of 2 or 3 major things. I think one is around communications, particularly with people who are shielding, and this is a really important thing to get right ahead of a second wave, which I very much hope won't materialise. But if we are going to be asking people with long-term health conditions, serious long-term health conditions, to start shielding again, we've got an opportunity to do a much better job of it. So what we found the first time around was there was very little clarity as to who should be on the shielded patients list. We were given very broad categories by the NHS, but that didn't account for the very significant differences between different medications that people are taking and different severity levels of their illness. What that meant was that people didn't know if they were shielding or not. Some people received letters telling them to shield, which their GPs didn't know why they'd been sent them. Other people were removed from the list by text message, in some cases with no warning. And all of that just really adds to this feeling of, stress and, really feeling that people didn't know what was happening and didn't know what they were being asked to do. So I think aligning those communications much better and being clearer on the exact criteria about who we're asking to shield is really important. And then I think offering proper support for people who are shielding as well. So there was the NHS volunteering service, and I think perhaps more significantly a huge number of local groups and local networks which sprang up around London and around the country, which were offering help for people. And I think a lot of that was focused on access to food and access to medications, which is going to be the top priority. But I think beyond that, I think really thinking about how we can support people who are potentially not leaving their homes for weeks or months at a time, making sure that they're not lonely, they have opportunities to connect with people, and they can access mental health services if they need it, is really important.
Thank you, that's really helpful. I wanted to ask, you did mention it about shielded workers and work and concerns about job prospects and so forth. But obviously the government has now paused shielding. Do you have any evidence, whether anecdotal or otherwise, that has caused great concern amongst those who have pre-existing conditions? And what more does either the government or perhaps individual employers need to do to ensure that those concerns are alleviated?
Yeah, absolutely. We've been asking about this in our surveys as well, and I think people who've been shielding are very worried about the prospect of going back to work. 1 in 5 people even said that they would lose their job before they left their home and went back to their workplace. I think that what that comes from is a lack of confidence in the ability to make all workplaces COVID secure. And I understand that there is some quite detailed guidance, and individual employers, hopefully most of them, are putting a lot of effort into trying to make the workplace as secure as possible. But then I think we've obviously also seen lots of news stories about workplaces, particularly factories, being the kind of real sources of new outbreaks. So it's understandable why people are particularly worried about that. I think for what we can do about that, I think part of it is the onus is on employers to be responsible, to make sure that they're not asking people who've been shielding to come into work unless they really need to do it. So making sure that you're still offering home working options, redeploying people to less risky parts of the business where that's possible, and having that real two-way dialogue with people about what they think will be safe for them to do. From the government's point of view, I think we all know that there's likely to be a small number of people who just can't go back to the job they were doing before. So, examples of that could be jobs where there's a lot of customer-facing or public-facing contact, possibly some healthcare workers, who could be exposed to a lot of infected people. And I think there's a real gap there in the government's plans around what will actually happen to those people when the furlough scheme comes to an end in October. So I think the big ask to the government is to look at whether there's a possibility to extend that furlough scheme for people who just genuinely cannot go back to their place of work safely, to make sure that they have that financial security and are not going to face a cliff edge when that comes to an end.
Thank you, that's really helpful. Thank you, Chair.
Thank you. Can I call in Assembly Member Susan Hall, please?
Thank you, Chairman. These questions are to Nikki Morris, please. So what has been the mental health effect of lockdown on older Londoners, and what action should be taken immediately to protect the mental health of older Londoners in the event of a second wave or localised lockdowns?
Yes, so thank you very much for inviting me and allowing me to bring my evidence to your meeting today. One of the issues that we've found is that it's exacerbated an existing problem. So they'd already been nationally highlighted an issue that older people are at risk, significant risk of depression and anxiety, and that the effects of COVID have exacerbated that. So some of the key issues already existing was around that in society you often think that mental distress is normal in ageing, and that needs to be changed. It's not normal in ageing, and people need to access mental health services in the same way they would do at any other age. Participation in meaningful activities, relationships, physical health and poverty. So all of those, if you look at them, were issues during COVID. So with the idea of isolation, loneliness, heightened perception of risk, you know, to illness and death and bereavement were all issues for the older population during COVID. And as Vicky said earlier, the digital exclusion as well for some people during COVID. So I think, and as Vicky said, there was a decrease in referrals. So whilst on the ground we know that there's an increase in need, there was a significant decrease in referrals into the mental health services. So we need to be really acknowledging that and making everybody aware that that's happened, because unless people are aware, they won't realise to do the assessments and make the necessary referrals now. And that needs to be put in place before, as soon as possible, because we talk about a surge in referrals, there needs to be one. And if there isn't one, we need to question why. And we need to be dealing with that very quickly, I think. I think we need to understand the impact of isolation and loneliness and living with anxiety, that threat to illness and life, and that's for everybody. We need to look at people who are falling through the gaps. So if we think about them, you know, the people in care homes are people that often fall through the gaps because they think that they're being looked after, and they themselves have had some isolation from family and friends, and also often suffered bereavement of people close to them that they live with. We've got those who are very frail, those who are digitally excluded, and those who are in a caring situation that have become more isolated. So I think putting things in place to identify what the problems are now it is really important, and making everyone aware that we need to be assessing people very quickly, and we need to be getting people into these services very quickly, and that we need to be assessing very quickly should there be a second wave. But I think we also need to be supporting those befriending services, so looking at that lower level of support with people so that they've got that support before that their mental health might deteriorate due to a further lockdown or for a long period of isolation.
Okay, so do you think it's been made worse by the fact that getting into GPs has been so difficult during this period of time?
Yes, I definitely do. And I think it's been more difficult because it's not been face-to-face. So what we know normally is that older people, about 40% that visit their GP have got a mental health issue that's often going alongside another issue. We know that there's lots of comorbidities, and a GP not sitting in front of somebody face to face, being able to explore that, I think has definitely been a factor.
Yeah, I agree. I mean, did you raise issues about this or about social care during the pandemic with the public authorities?
Yes, I think the only thing that I think was happening was that there was such a it took a while for that pattern to emerge. So it took a while for us to understand the referrals were dipping. And so that's something that we know now and need to put things in place to prevent going forward. So I think some of the impact has inevitably taken a little while to come through, and therefore we need to act on it now.
Okay, so I mean, bearing in mind it's been 4 months, so when you recognised it, whenabouts was that? And when you brought it up, what was the result of that?
Well, obviously I'm working just in the borough of Camden, and on a local level, we've talked about it with our GP colleagues, and I think what we've done is raised awareness around and making sure that people ask the questions. So I think we're dealing with a difficult issue. By the time it revealed itself, we'd got people who were nervous about going out of the house, so nervous about going to a GP surgery, as well as at times not being able to access an appointment. So one of the things that I think has been done locally with the GPs and the social prescribing and care navigation is making sure everyone's asking the right questions.
Have you requested that more people are seen face to face? Have you brought that up at any point in the last 4 or 5 months?
We haven't discreetly said that. So we haven't said that as a point to say, can you do that now? And I think that was because there were many factors that were being brought into that. But I think with our review of our learning through it, it's absolutely one of the things that we talk about, and how to do that safely for people. So not only safely from a physical point of view, but how they feel they can access it safely.
Okay, I'm just mindful, obviously, the government will be looking at this, and I'm wondering who's highlighted things as we've gone along to say this isn't happening, as opposed to at the end of it all when, you know, the typical lessons have been learned. But at what point did anybody highlight that there were issues coming with GPs not being where they should be, or at least seeing more people face to face? I mean, what actions would you like to see the Mayor take to support older people, given the crisis we're in?
Well, I think raising the issue about older people mental health, accessing mental health services has got to be something. So we've got to actually look at the referral rates and the effectiveness of the interventions with older people, and that has got to rise. We should have seen a rise anyway without COVID, and we've got all of the things in the mix of COVID to make the mental health of our older people worse. So we have to hold people to account of assessment, and then making sure that they access the mental health services that they need, and that those mental health services are effective. But I think we also need to look at that slightly lower level, which is around, we should have a befriending scheme across London, and I think it should be linked with an age-friendly London, so that those older people who are currently in isolation and feeling aspects of loneliness have got a link to social interaction. And I think that's the first foundation of good mental health, and will prevent a deterioration.
Good. I mean, are you doing some sort of report on lessons learned? Because in hindsight, we all know what we should have done differently and better, and alerted authorities sooner. Are you working on that in Age UK?
Yes, we are. Yes.
Excellent. Good. Okay. That's it. Thank you, Chair.
Thank you. Just talking particularly in terms of the elderly population for age concern, one of the other problems, of course, in this group is their dependence on social services, and that has been the something which has been broken down and needs mending. And I don't know if I mean, there are no other GPs here, right, to defend the position of GPs, right? But I just want to talk about the impact of social services, right? Have you found that how this has impacted on people during the COVID-19?
With the delivery of social services,
yes.
you're talking about?
And social care, because well, I mean, I found my elderly patients have been suffering from things like loneliness, not getting the help they need, not being able to get to social workers, not being able to access the service they rely upon. Okay, and that's what's really let them down. And some of the elderly people are held up in hospitals, but they can't come out in the community. But the social care system is broken down.
At this point, I'd quite like to champion Camden, as probably I might, in that I think our response was an excellent response to CCG, the council and the third sector working together. And I think there is something across London and something nationally that people could learn from that, because I think it was an example of those bodies working together along with the wider community. And I know from talking to my colleagues that wasn't the case elsewhere. So I do think that was a very effective way of doing that, and I think there were lessons learned around that, and some good practice around data sharing and coverage of the borough, and lessons learned meetings as we went along. So it wasn't perfect, but I think it was better, and I think what it does show is it does show actually the third sector, the way the third sector can be flexible and can feed into some of those systems and can be the advocate for older people. So I think there was an issue, of course, with social services, and I think there was an issue around some, particularly at the beginning, around, for instance, PPE, where some people weren't having social services come in because there was an issue around obtaining PPE for it to be safe, but there was also an issue around older people not feeling safe, having people coming in. And definitely there was an issue for older people about, and it goes back to a point earlier, about who they trust. So having some of these networks in place so that people have somebody they already know and an organisation they already know to advocate on their behalf was absolutely imperative. And the other thing that I would say is things like day services couldn't continue during the peak of the pandemic. But many services, many organisations continued to deliver hot meals, welfare calls, the sorts of things we did during the pandemic, which I think was imperative, because those people weren't then left with nothing, but also weren't having new people coming in that didn't know them, and therefore couldn't respond to their needs in the same way that people who did know them could.
Okay, fine. The other thing, I wasn't entirely sure. You were saying that your clients couldn't get in touch with the GP services. The GP services were open all the time, and of course the elderly population were one of the specific groups which were most vulnerable from COVID-19. They're the ones who were one of the high risk groups. What aspect of the GP services was it that they found most stressful? Given the fact that GPs were there already in the surgeries, right? I mean, they couldn't see them face to face, right? But what was the aspect that they found most disturbing?
The thing that they found disturbing, and I would say this was where the care navigation and social prescribing was very helpful too, as a link. Yeah. So we worked well with the GPs and well with our care navigation social prescribing, but I think it was the complete change in how people were able to access them or not. So and there was a lot of, particularly at the beginning, around prescriptions, for instance. So there was a lot of traffic of requests going in and out of GPs around prescriptions and how people could get them. And so a lot of issues were rather taken over with certain things that became a huge anxiety for people, which then meant that people felt they shouldn't access their GP for something that they felt was less important or not COVID related. They also found it very stressful to access the GP, say, over the phone or online doing what we're doing today. And I think as well found that they kept it to one issue, whereas sometimes the mental health is an issue that's running alongside other things. So they tended to keep things to the very important and felt that's what they should do.
Right. Yeah. I understand that of course there has been digital exclusion of people, and those people, I think, have been particularly challenging. We need to be mindful of that. Great. Thank you for that. Can I call upon Assembly Member Andrew Boff, please?
Unmuting isn't as simple as it's said to be. Thank you. Can I just ask to all the guests, what roles do the Mayor and the government need to play in responding to the long-term mental health effects of COVID-19? Also, I specifically also want to know, what should the Mayor do in the short, medium, and long term to make people more resilient?
Can I come in there, Andrew? Lynette Charles from Mind in Haringey. I think that we need to really recognise the role that the community and voluntary sector and grassroots organisations played in the initial lockdown. To give you an example, in our organisation we took 650 people with us to remote working, and that meant that those people didn't go out and find stuff. We were having conversations with them. Haringey is a good example. We have 1,000.
We may have lost you there, I'm afraid.
Organisations were crucial in that. I also think that we all worked really well together in crisis. Oh, sorry, I was just going to say that I think we all worked really well in crisis. So the good things that we established, we make a plan if we do find ourselves in lockdown. Trying to remember those things that they called on. That's going to be a lot about the deprivation in Haringey, people losing their homes, their jobs, etc. I don't know if you still got.
I'm afraid, Lynette, we're not.
Sorry, I didn't hear any of that.
I'm afraid, Ms. Charles, we've got we're missing a lot of your evidence, possibly for connection reasons. But I think you've made the point very, very well, despite that. But the third sector really stepped up to the mark during the COVID-19 crisis. I wondered if there was something we could do to recognise that, or to support those community groups who did so well. I don't know if Ms. Charles, you want to come in, or perhaps one of the other guests might want to come in as well. General quiet.
I can come in just on the first aspect about kind of what could the Mayor do around this. With health in London, it's a real mix, isn't it? There's some very specific powers, but then when you look at kind of how COVID has been dealt with, it's been a real kind of central government push down. So there's something about getting the balance right. But from my perspective, I think what the Mayor and the Assembly, by extension, have are a number of different levers to influence both the delivery on the ground of services, but also the symbolism and the messaging that comes out, the narrative that comes out about mental health being just as important as physical health during COVID, and to make sure that attention's being paid on both. So we obviously have things like Thrive London that are already up and running and well established, looking at the kind of mental health and well-being of Londoners. What more can be done through that medium to push that message out? I think there's also there's normally a seat round the table on the various kind of NHS-led boards which focus on mental health in London. The London Transformation Board, I used to sit on that, and I think it's checking in with those to say, well, what are the plans looking like? Are they fit for purpose? What more needs to be done to make sure that people don't fall through the gap, that referrals still are able to take place, and I think there's a real focus that could come on kind of the mental health of our children and young people that could be led from City Hall onwards, because we know that they've really struggled with the closure of schools, and a lot of the focus has been on getting schools back and up and running, but for education reasons, but not so much on the kind of the mental health and well-being of those students and the pupils that are coming back. So there's some ideas on what I think that the mayor could do, and how you can hold him to account, but also kind of use your own influence in your own community to make sure that the right conversations are being had and that mental health isn't forgotten about.
Absolutely, and that's certainly something the assemblies will treat as a priority, I think. Can I just ask all our guests whether or not they've had any, whether or not they've been included in any of the work by the London Recovery Board, which of course is the Mayor's vehicle for getting London back to where we live. Anybody?
This is Sarah from Aston UK and the British Lung Foundation. I don't think that we have. No. You
haven't. Anybody else? No.
We haven't from National Mind, but I can check to see whether it's happened through our Mind in London initiative, which Lynette would sit on. Lynette might know, but if not, we can double check that. But if we're not, we'd love to be involved.
Well, I'd love you to be involved as well, and I very much appreciate that if you could get back to us and say whether or not you've been involved in the London Recovery Board. Of course,
and I can, sorry to interrupt, I could also check with Age UK London.
Please do. Thank you so much for that, because we do think that, well, I think we've come to the conclusion that, you know, we've got to all feed into the policies that will make life better for those people. Do you? Of course, there are other areas as well. That's in the short term. The mayor could be doing some stuff. What about the long term? Do you think his policies stack up in terms of providing good mental health?
Yeah.
Can I just step in, because I just want to say that I think it's really important around the stats. So just to I think absolutely right, Vicky's absolutely right about that, making sure the right conversations are had. I think we need to make sure we've got the right evidence, and some of it is about what stats are we missing, you know. So I think that's a really important thing. I do think that the Age London initiative is a good one, because from as we've seen today, from an older person's perspective, there are many factors that go into your health and well-being, and this is about your everyday life. So I do think that the age-friendly work in London is a good one, but there needs to be a drive that the whole of London participates in that, and an accountability that it happens. And I think there does need an accountability around setting some initiatives and targets around referrals into mental health and looking at the outcomes of those for certain groups.
Anybody else on that section? To what extent are immediate environmental factors affect? Have they affected people over the period of pandemic? I'm thinking particularly of housing conditions. Is that a very significant factor in mental health?
Housing is definitely a factor, and being able to get to the outside safely is a factor. So we have issues around maintenance of buildings and lifts in flats. If they don't work, people can't get out. And transport is another issue. Supporting people to get out to their GP surgeries or their hospital appointments. And some of it is not just about, we always call it, it's not a curb-to-curb transport, but how do we get people out safely from their flat to the vehicle and out the other end? So housing and transport remain an issue that again was exacerbated during COVID.
Do you therefore think it would be a good idea for the Mayor to review his policies based upon the experiences of those people who've had mental health issues during the pandemic crisis?
Yes, I do, and I think it would be very interesting. I think we definitely should. COVID has had such an impact, and I think it should be those who have had existing mental health issues, and also those who are new, who've had a new mental health issue. So, and I think those are very interesting two parties. And from third sector point of view, 50% at the peak of the pandemic, 50% of people reaching out to us had never reached out to a charity before. So that showed a very quick and impactful way of change of behaviour. And that had mental health issues. For many, they found it very distressing that they were having to ask for help from a charity.
Thank you. I mean, we'll probably, I will take that message of the Mayor needing to review his policies in the light of COVID-19. We'll be taking that message to the Mayor.
Thank you.
Chair, in a roundabout way, I think I've
Andrew.
answered my... I beg your pardon. Who wanted to come in?
Sorry, yeah, it was... my internet is unstable, so
Yes.
I might just switch my camera off. But there's a point to say is that we absolutely know the connections between housing and mental health, but it's also about how much money people have got to live on. It's about your finances. It's about all those things that wrap around the impact on your life that can have an impact on your mental health. And there's definite leverage that, again, the Mayor can look at what he can do, what London can do in the medium and long term around some of those plans. And just to pick up on the contributions from the session before this, is in our own research we found that that people from Black, Asian and minority ethnic communities actually had a greater negative impact. COVID had a greater negative impact on their mental health than the white population, and particularly issues around housing, employment and finances had a greater impact on their mental health worsening compared to the white population. So there's definitely something going on that needs a bit more unpicking around that. So I would want to make sure that that's picked up in that medium and long-term strategy as well.
That's very helpful, and certainly do you think therefore that any review of the Mayor's policies which left out housing wouldn't be a complete review at all?
I mean, housing absolutely has to be central to that. We know that it's been one of the root challenges within COVID and tackling COVID. So yeah, housing is absolutely key to how we move forward.
Thank you for that. Anybody else before I... Yes?
Yeah, I just wanted to come in briefly on what more the Mayor could be doing. And I think, like other people have said, I think a big part of that needs to be about using various levers of influence with central government and with NHS England to be making the case around better support for people who've been shielding and people with long-term health conditions. But I think there's perhaps a specific point about communications for people who've got a chronic health condition, certainly for people who've got a lung disease. The mental health effects of COVID are very strongly tied to their fears about their physical health, and for some people, kind of fears about having the very negative impact that COVID would have on them, and potentially even death as a result of that. And I think that something that would help people feel more reassured would be more communications and messaging going out about the things that are being done which will make them safer when they're out in the community. So whether that be messages about social distancing and reinforcing the need to wear masks in appropriate places, or communications aimed at the general population in London to make sure people understand that there are still people who are at high risk, and therefore that's why we all need to be taking these steps to look after each other. I think that would be helpful and would reassure people that their condition is still being taken seriously. And I think the other point is about data. So again, people are obviously very concerned about their own risk of catching COVID. And I think it can be quite hard to access clear information about what numbers are like in your local area. But in many London boroughs, certainly new cases now are very low. There's some fluctuation, but in some London boroughs, it's very small numbers of new cases each week. And I think being able to access that information more easily would perhaps help people feel reassured about being out and about in their local areas, and would lessen some of that stress and anxiety. So I think that's, again, something where the Mayor could maybe play a role in communicating some of that information.
Thank you. Thank you very much. Chair, I know I probably went the wrong way round, but I think my questions are now answered.
Great.
Thank you.
Thank you, Andrew. Can I ask to bring in Assembly Member Hall, please?
Thank you, Chairman. Mental health issues are absolutely important to all of us, that they're sorted out, and too often it's been ignored. I note that this morning there's a report come out from Northern Ireland saying how concerning it is that so many school children, because they've had their education disrupted so badly, are showing signs of mental health issues, which obviously is of great concern to us all. So everybody that's here that's an expert, if I can say, do you agree that schools absolutely have to go back to some sort of normality, else we could end up with a real problem? And if you do think that, can you tell us how you think that we could persuade the Mayor to persuade schools, unions, etc., to make sure that those schools are open for those children on so many levels? Thank you. Anybody like to start?
I can start that. I mean, absolutely, we know the vital role that schools play in supporting the kind of both the education development, but also the mental health and well-being of young people and children. And so in the absence of the schools operating, that's why we've seen such a dramatic drop in those CAMHS referrals, which are really, really worrying. And so, yeah, we'd very much encourage the schools to kind of get back to as much of a normality as possible. Yeah, I have a 6-year-old son, and we live kind of in Merton, but on the border of Wandsworth, and actually the primary school, I think, did an amazing job. They got the kids back as soon as they could. They adapted the school routine, so they were going in mornings, and the planning that went around that gave us as parents real kind of confidence that it could be done, and it could be done safely. But we know that's not the case across the board, and we'd also be really worried about those when kids do go back and they may well be developing and experiencing mental health problems, we have to have some understanding about how that is going to manifest itself, because what we don't want is a sudden immediate kind of increase in suspensions and off-rolling and school exclusions, because they by and large tend to affect particularly people or children maybe with undiagnosed mental health problems, or people that are struggling with their mental health. So we want to be able to get schools up, and we want people to be able to stay in school and for their mental health and well-being to be supported. That's a lot to ask for, but if we can do it for other parts of the economy and society, I'm pretty sure we should be able to do that for our kids in a safe way.
Absolutely, and I think you're right, it hasn't been the same everywhere. My 6-year-old grandson has hardly had any education since March. Would anybody else like to comment on this? No? Well, I'll take from you, Vicky, that you're positive about schools going back, and we must be asking the Mayor to do all he can to ensure that the London schools, if nothing else, go back. That's it. Thank you very much, Chairman.
Thank you. Thank you. Okay, that brings us to the end of this session. Can I thank all the guests for their contributions? And can I also ask the committee to note the report and the subsequent discussion and delegate authority to me as chair in consultation with the deputy chairman to agree any output from this discussion? Thank you. Can I please ask also the committee to note its work programme as agreed under delegated authority by the chair of the GLA Oversight Committee on the 30th of May and 20th of July. Can I ask the committee to nominate me as chair to represent the Health Committee as a partner to the Middlesex University and Imperial College London project on wastewater-based epidemiological surveillance system for COVID-19 containment, a pilot study in London up till and until May 2021.
Agreed.
Thank you. The next meeting of the Health Committee is currently scheduled for 14th of October 2020. However, as discussed this morning, a pre-meeting, we're looking to reschedule this, and I think the dates have been agreed, haven't they? Yeah. There are no other items of urgent business, so I call this meeting to the ending, and I'm sure a lot of Assembly members will be relieved to hear that.
Thank you.
Great, thanks.